are happy and delighted to welcome Dr. K.R. Ramanathan, Senior Consultant Cardiac Thoracic ICU, NUHS and Adjunct Associate Professor at the Department of Surgery, Yong Lu Lin School of Medicine, National University of Singapore. He is a globally respected leader in ECMO and also other mechanical assist devices. Dr. Ramanathan brings unparalleled expertise in extracorporeal therapy. He needs no introduction, at least in this part of the world. So we have thoughtfully curated the talk for him. And this talk is all about ECMO and CRRT or CRRT. So Dr. Ramanathan will address one of the most pressing challenges in the extracorporeal organ support, the integration of CRRT patients on ECMO. So we have created one clinical vignette, and he would be exploring the decision-making process, balancing the hemodynamics, metabolic control, and renal support. So I am very sure, as he is world doyen in this part and also in this domain, so this talk promises practical insights that blend cutting edge science with bedside applicability. Over to you, Dr. Ramanathan, for your insightful talk.
Thanks, Tapas, for that lovely introduction. You have hyped me up a lot. I'll try to live up to the expectations. I know it's a fag end of the conference. You have had 2 days of great conference, and clearly, this being the last session, I know what is expected of me. It's just that I don't know how to do this differently. I'll be as short and slick as possible. Clearly, talking about extracorporeal circuits in general, and that too in say 15 to 20 minutes is a daunting task. I have 2 circuits given to me, and I've been asked to manage a patient who needs CRRT. Clearly, it's not something which is difficult as long as you understand the basics of the circuit. Not only do you need to understand the basics of the circuit, when you have 2 extracorporeal circuits, clearly there is a crosstalk between the circuits, and we need to understand the language if we need to treat patients who are on 2 circuits. So let's dive a bit deeper. This is what I've been told. I've been told that this patient is on VV ECMO and he develops anuria with a rising lactate. How do we proceed? So clearly, it's something which we get to see every now and then when patients are on VV ECMO. Of course, my initial differentials would make sure that there are no reversible causes of this. Clearly, the fact that the lactate is rising worries me. There is some element of tissue hypoperfusion in this context. And add on to that anuria from a pathological cause, you need to be doubly worried, and you need to find your exit strategy properly out. Clearly, ECMO is here to give him support in terms of his respiratory failure. But this patient most likely is now developing a super added acute kidney injury as part of the whole disease process. And the next few slides, I'm going to substantiate how CRRT in this context can be useful, can be used to salvage the kidneys. And we will also look at some of the outcomes of these patients who need CRRT. But at the outset, please understand that it's not the CRRT or the ECMO that decides the course of acute kidney injury in this patient. The fact that his organs are failing is more important. And the fact that he's now got at least 2 organs that have failed makes him...
Dr. Ramanathan, sorry to interrupt. Your slides are not moving. Are you?
Yeah, I'm not moving my slides.
Thank you.
I'm not moving my slides. So makes it the fact that two organs getting involved is equally important to analyze, assess, and as intensivists, we should be supporting them appropriately. So, primary question is, when do we need or why do we need a renal replacement therapy on ECMO? The few conditions that clearly warrant CRRT on when a patient is on ECMO is when multi-organ failure progresses. Progresses to the point that it involves the kidneys, and you have the patient developing acute kidney injury, like how we saw with this patient here who's developing anuria. So we need to quantify that and figure out whether we need to start CRRT at an appropriate point. At what point do we start CRRT? I'll discuss that. The other indication, which is a softer indication for CRRT on ECMO, is that patient who is quite fluid overloaded. Many of these patients are septic and they would have been fluid resuscitated in a big way during their course of treatment. And by the time they come on ECMO, they are positive by, say, up to 10 to 15 liters. So these patients clearly need to be managed differently. So CRRT on accounts of fluid overload is also an important concept among the ECMologists. The other indications where you need CRRT on ECMO basically pertains to toxicology. So you guys know it better than me. There are certain toxins that are cleared only by CRRT. And as a process of stabilizing your patient on ECMO, you initiate CRRT once the patient is more stable to go on CRRT. Very often, when you are on 3 inotropes and your patient is struggling, it might be difficult to initiate CRRT. And ECMO in this context gives that bridge or the balance in terms of hemodynamic stability to start CRRT. So broadly speaking, these are the indications for CRRT on ECMO. Now, while we talk about that, you also need to understand that AKI combined with ECMO is quite common because these patients go on ECMO for the simple reason that they are very sick. So it is very common that they have associated multi-organ failure. And not all patients who end up having AKI end up getting CRRT. So CRRT and ECMO probably has a different epidemiology when compared to AKI and ECMO. Not much different, but still, we'll just look at some of the numbers. So if you look at patients on ECMO who need dialysis, it's about 45%, while if you look at the overall incidence of RRT on ECMO, it's about 50%. And in fact, VA ECMO accounts for more AKI. You can very well understand the crosstalk between the heart and the kidneys and the cardiorenal syndrome that ensues. So clearly, VA ECMO patients end up having more AKI. And clearly, when VA ECMO patients, when you look at the literature, the percentage of patients requiring CRRT is definitely more than those who need it for VV ECMO. So our patient here, who is on VV ECMO, needing or developing AKI is quite rare compared, or when I say rare, relatively rare compared to a patient who is on VA ECMO. So I'm a bit surprised that this guy has needing or is gone into AKI, even if you go by the epidemiological statistics. Clearly, when your patient develops AKI and he's on ECMO, it clearly impacts on the duration of ECMO and the ICU length of stay. And eventually, clearly patients who end up on RRT or renal replacement therapy on ECMO, the mortality is higher than just ECMO alone. Again, VA ECMO in this context has a higher odds of mortality than VV ECMO. So that way, I'm a bit reassured that this patient is probably he might benefit out of out of RRT, and his mortality is not that high compared with VA ECMO. And on the same grounds, I'm also worried that, as I told you earlier, in these patients, it's the degree of sickness which essentially relates to the extracorporeal support that is required. Rather than blaming the extracorporeal circuit for mortality, I would think it's more often the other way around, that the degree of sickness most often determines their overall outcomes. Now, if you look at a patient who's on ECMO, his chances of developing AKI are manifold, and there are many reasons to that. You can have patient-related problems such as this patient has a severe respiratory failure, so problems with gas exchange and VQ mismatch, which can contribute to right heart dysfunction or which can even directly lead on to end organ damage. Then you put him on a ventilator just because he's got respiratory failure. You are iatrogenically introducing many components that can contribute indirectly to renal failure. Of course, when this patient goes on ECMO, this patient develops a SIRS response. So there is an inflammation, and clearly it affects the microcirculation. With relation or in relation to the circuit that's been started to salvage this guy, this patient is at risk of developing hemolysis, thrombosis, and all of this can contribute to AKI in many ways. Last but not the least, I did speak about RV dysfunction. You also need to understand that these devices which we are using for such sick patients have a continuous flow pattern, unlike a pulsatile pattern, which is natural. So clearly, there are some interactions between the type of flow that is encountered by these machines and the pathophysiology of AKI in these patients. Clearly, a lot of these patients who develop acute renal failure are seen in the post-cardiotomy group. But having said that, you need to also understand that when patients on ECMO develop AKI, the most common mode of dialysis used, as in critical care, is CRRT. And RRT in this context, as I said earlier, not only helps support the kidneys, it also enables better electrolyte, it also clears electrolyte disturbances and prevents fluid overload. As we always have a debate about when is the right time to dialyze a critically ill patient, the same confusions apply to patients on ECMO as well. There is no consensus on what the optimal timing for CRRT is. Now, in terms of fluid overload, when it comes to ECMO, clearly, most of these patients on ECMO, there are no specific guidance on fluid and electrolyte management. When your patient stabilizes on ECMO, there is a tendency to resuscitate them more. So the amount of permissible fluid resuscitation is slightly higher in these patients, making them more positive. But then what we fail to recognize is the ideal timing of fluid removal. So if you look at patients who are on ECMO already, they are vulnerable to additional fluid therapy in terms of blood transfusion or fluid loading. But again, there are certain situations where, by virtue of the ECMO machine behaving oddly, say when there is chattering of the circuit due to hypovolemia, we end up giving more fluid than required. There is also this unintentional fluid therapy that comes through the circuit. Of course, in terms of the underlying disease, this can interact with whatever is happening on ECMO to accentuate the situation. Again, when it comes to fluid removal, as I said, given that there is no consensus on the ideal timing of fluid removal, there is also no consensus on the rate of fluid removal or the total amount of fluid removal. What we have are a group of good observational studies from big databases, which has looked at it, and we have only extrapolated some of these findings to say, okay, we need to start dialysis on such and such date. This patient should not be fluid positive beyond such date, and ideally, this much amount of fluid is feasibly removed while the patient is on ECMO. So these are some of the observational studies I was talking about. And again, the outcomes based on these studies are quite variable. So if you look at the evidence per se, it's a mixed bag. If you look at any system for that matter, China, France, Germany, Australia, Korea, you'd find that the use of CRRT as well as the quantification of fluid balance has been quite different. and hence outcomes have been different between the studies. One of the larger studies that got published in this context is from Korea. It's from Asia itself. And this patients looked at about 700 odd patients on ECMO. And they looked at the relation between use of CRRT on ECMO and 90-day mortality. One component which they looked at very closely is cumulative fluid balance. So with cumulative fluid balance going up, the 90-day mortality was higher. What was more interesting here was the cardiac ECMO group had a higher mortality at a lesser cumulative fluid balance, say at about 80 mils per kg, as compared to the respiratory group, where the cumulative fluid balance was more when the mortality risk started shooting up. Now, Matthew Schmidt and his colleagues looked at a similar impact of fluid balance in patients undergoing ECMO. And this was a very nice study that looked at the impact of CRRT on ECMO. And they figured out in that particular cohort, and this was mainly the Australian cohort which they looked at, the 90-day mortality was only about 25%. Again, an important finding of this study was as long as you fluid resuscitate your patients when it is required, say in the acute phase of sepsis, you can do it, say, up to 3 days. Between day 3 and day 5, you need to show, or at least survivors showed, that the daily fluid balance was coming down. So making it clear that resuscitation up to 72 hours on ECMO might still be a good thing to do, but you need to start squeezing them out by day 3 to day 5. Clearly, positive fluid balance on ECMO day 3 is definitely an independent predictor of mortality. Again, similar findings were shown in other studies as well, showing that negative fluid balance was associated with a survival which was better. So in this patient who is on VV ECMO, who is anuric, if I aim for a negative fluid balance, at least starting day 3, my chances of successful VV ECMO survival is quite high. So going on to say that this goes hand in hand. I did talk about the other indications on ECMO being toxicology. Few of the cardiotoxic agents are invariably supported on ECMO. This was a paper on amlodipine poisoning where we used 3 extracorporeal circuits, in fact, where we used CRRT, we used an ECMO circuit to stabilize, and then we tried to remove the amlodipine using total plasma exchange, making it a bigger project whereby you can use ECMO to stabilize so that you can use the hemodynamic stability to give the right extracorporeal therapy the patient needs. Similar kind of approach has been used in thyroid storm as well. So when your patient is hyperthyroid and has a thyroid storm which is uncontrolled, you may find that they are very arrhythmogenic. So you stabilize them on ECMO and use plasmapheresis to remove the endogenous thyroid. For all those postgraduates, I use this code to tell them what are the dialysable toxins. So I remember them using the mnemonic I stumble. I stands for isopropranolol, S is salicylate, T is theophylline, U is uremia, M is methanol, B is barbiturates, beta blockers, L is lithium, and E is ethylene glycol. So the decision to CRRT, when you stumble, you remember the password in toxicology, I stumble. Now, coming to the various modalities which can be used on ECMO. So you can use CRRT, and that is the most common. Clearly, it has high cost. The patient is going to be immobilized, but it's easy to integrate in the ECMO circuit. You can also use SLED, which is also, you need to look at the hemodynamic instability before you decide on it. It is possible to integrate the ECMO circuit, the SLED circuit into the ECMO circuit as well. It's got lower costs than CRRT. IHD is rarely done. I would say sparingly done. It enables rapid fluid removal, but then, you got to understand that it comes at a price of when you have rapid fluid removal, you might end up having problems with the ECMO machine. Peritoneal dialysis, yes, has been traditionally, has been used. Again, it's less experienced in adults. It's more done in pediatrics. Now let's come to the circuit adaptations for RRT, because this is something which is going to impact eventually on how the machines talk to each other. Now the ECMO has a pump, a membrane lung, and or what we call as the oxygenator, and of course the cannulas. So pump, membrane lung, and cannulas. To this, you can always introduce the circuit. The question is where or which part of the ECMO machine do you introduce the circuit? You don't need an ECMO machine or a CRRT machine. Actually, you can very well connect the filter directly to the circuit and make it work. But then a lot of things will not be controlled when you do it this way. So it's best done using an ECMO machine connected to the circuit. The ECMO machine can be connected to the different parts of the circuit. So clearly, there is a part of the machine, ECMO machine, that is pre-pump. There is a part of the ECMO machine that is between the pump and the lung. And there is a part of the machine that is beyond the membrane lung and the patient. So the connections to the CRRT machine can be in any of these parts. Generally, we tend to avoid the part between the pump and the patient, because this part of the ECMO circuit has negative pressure. And if you were to introduce three-way the three-way channels there is a good chance that air will entrain into the ECMO circuit. So you don't want that to happen. So you avoid that part of the circuit. Clearly, the other way would be to connect the circuit post-pump and the return from the circuit into the ECMO machine post-membrane oxygenator. So again, this gives you the advantage that whatever blood that goes from the ECMO circuit to the so from the CRRT circuit to the ECMO circuit will get flushed inside the membrane lung, and small bubbles can be washed away or removed. So clearly, you have many options. You need to evaluate each one and select what is best. There are certain things you definitely avoid. As I said earlier, some part of the circuit you don't want three ways, but the other parts of the circuit, you can still use them to configure your RRT and ECMO. So these are some of the advantages and disadvantages of using various configurations. Of course, I spoke about the inline hemo filter, which has no pressure monitoring and less precise ultrafiltration, as compared to where you have a patient who has ECMO circuit integrated, CRRT circuit integrated into the ECMO circuit, what we call as the integrated RRT ECMO circuit, which allows fine-tune adjustment of solute and fluid removal. So clearly, these are things which you need to know. The biggest problem here is usually the pressure alarms in the CRRT circuit. Most of the newer machines that are currently available are used to such high access pressures, and hence, the pressure alarms can be adjusted to maintain RRT on ECMO. So these are some of the different ways of connecting it to the circuit, their advantages and disadvantages. Now, one thing that I can always highlight here is you don't always have to integrate a circuit into the ECMO circuit. You can always run a CRRT separately from an RRT machine. So clearly, you can separate these two and run it as two parallel circuits. It's equally effective and feasible. Now, when we talk about RRT dose on ECMO, clearly the optimal dose is unknown, but it's extrapolated from critical care. So what we usually do is these patients get 20 to 25 mils per kg per hour of CRRT, and the blood flow is maintained anywhere between 100 to 250 mils per minute. There are newer studies that are coming up, especially focusing on the technical aspects of anticoagulation, drug dosing, and mediator removal. So the use of regional citrate anticoagulation as part of ECMO and CVV HDF has been looked at by our Hong Kong colleagues, they found it feasible. While you cannot anticoagulate the patient with citrate, for ECMO, regional anticoagulation with citrate for CRRT is completely possible. There are guidelines from the ELSO about how you manage CRRT, fluid overload, and acute kidney injury on ECMO. I was lucky to be part of this guidelines group. It was a fantastic guidelines group. And we, in fact, looked at how you prevent CRRT in patients who are supported with ECMO by various means. Now, if you look at outcomes of these patients, because that's what we are interested in, we know that a lot of patients are sicker, hence need CRRT. But patients, clearly, if you look at single center studies, you'll find that mortality rates are more than 75%. From the registry, it's about 50% for respiratory group and much lesser for the cardiac patients, which is again quite a surprise and different from what we saw in our systematic review and meta-analysis. But one thing for sure, if patient requires CRRT right from the beginning, especially in the first 3 days, it's definitely an independent predictor of 90-day mortality. If you look at that Korean paper, what they figured out was patients who received RRT for more than 7 days, their long-term survival was similar to those who received RRT for fewer days, but they had a higher risk of end-stage renal disease and higher readmission rates. So clearly, going on to say that if not mortality, this group has a higher morbidity for sure. So this, to collate the literature findings, we did a meta-analysis looking at the use of RRT and ECMO. And our findings were essentially that what I have highlighted so far, most patients who are middle-aged males end up being on ECMO and CRRT with a mortality of about 60%. What is reassuring is the fact that in the last 5 to 6 years, the mortality for patients on ECMO needing CRRT has come down by 20%, making it or highlighting the fact that we are now starting to understand how circuits talk to each other, how we need to adapt, and what we need to do differently. And this is a reassuring aspect that despite having 2 organs failing, the mortality has come down. So in short, if I have to summarize this whole talk and look at this patient holistically, here the indications for CRRT on ECMO would be, of course, fluid overload, that is refractory to diuretic therapy. So in this patient, clearly a trial of diuretics would be warranted. And if it doesn't work, he would need to go on ECMO. He would need to go on CRRT. Again, we need to look at his renal parameters and decide whether his progression of AKI is pretty fast, and hence he would need CRRT. And I'm sure, given that I don't know what kind of toxicology he has, hopefully he has nothing and it's just an acute respiratory failure. We also can include the group of toxicology patients who need CRRT. The dose and circuit more or less extrapolated from critical care literature. You need to understand that there are multiple configurations possible between the circuit, 2 circuits. The long-term sequelae and mortality is still high, and clearly the fact that it has decreased in the last 5 years shows that our understanding has become better, and we hope that these things will improve over a period of time as we understand when to time the CRRT and how much of dialysis dose is beneficial in such patients. So clearly, there is more yet to come, and I think we'll hope for that day to happen soon. I'll conclude my talk here. Thank you.
Thank you, Dr. Ramanathan. Definitely, I would end with the punchline: when ECMO meets CRRT, it's not just a support, rather I would say it's a survival strategy. And your session has actually highlighted how timely integration of CRRT in ECMO can transform the outcomes, reminding us the innovation in extracorporeal therapy lies in the precision, timing, and the teamwork. So thank you very much. It's a testament from the 50+ attendees here in this hall, how we can take the NephroCritical care to the next level with all the types of extracorporeal therapy. Thank you very much for your time as well as highlighting the importance of this topic.
Thanks, Tapas. Thank you. It was really a pleasure coming for giving lectures at your course. You're really very innovative with your course design, and I can clearly see that at the fag end of the course, you still have people listening to the talks such as this. It's really a testament to the hard work as well as the innovative way you have put forward for this course when you designed it.
Thank you. Thank you, sir.